Hi guys, we're here with Dr. Chan today. We are going to give you guys some information on back pain patients in triage.
Today we're going to talk about triaging back pain. Back pain is a very common complaint that we see in the emergency department and can certainly range in severity or acuity from mostly low, but obviously we want to catch the very high severity or high acuity pathologies. So to start in triage, going back to basics and asking all the most pertinent questions would be important. So a mnemonic I like to use is old carts, OLDCARTS. So start off with onset is O is onset. How long has the pain been going on for? Has it been only the last few hours, or has it been going on for the last few years? Obviously, we treat those complaints very differently. Where's the location? L is for location. Is it in the upper back? Is it in the mid back? Or most commonly, usually, is it in the low back? D is duration, and C is character. Is it a burning sensation? Is it a stabbing sensation? Does it radiate? Is it a character that usually you'll often hear that it radiates like a electricity bolt down the leg? How far down does it go? Is it to the buttocks? Is it to the knee? Or is it all the way down to the toes? A and R is for alleviating and relieving factors. Have they been using any medications to help with their symptoms? Are they already on prescription narcotic pain medication? Are they on any muscle relaxants or over-the-counter medications? T is temporal. Is it worsened at night? Is it worse in the morning? That will help differentiate various causes of back pain. And then S is severity. On a pain scale of 0 to 10, how bad is this pain now? Once you get a good history, I think that can give you an idea of the severity of the complaint. Having an idea of how well the patient can ambulate is really important in back pain. So if someone is unable to walk, then you may consider a higher acuity triage than someone who is laying on the stretcher and unable to walk. Differentiating the reason they can't walk is really important. Are they not able to walk because the pain is so bad, or are they not able to walk because their legs are weak? So the next thing is making sure you ask about the mechanism. Is it traumatic or non-traumatic? If it's traumatic, did they? What was the reason that they fell? Did they fall because they slipped on ice? Then we can concentrate purely on the injury versus did they feel dizzy or have chest pain and passed out and fell. Then we have to expand our scope and look for the reason why they were having chest pain or dizziness or shortness of breath before they fell. If it's non-traumatic, which is pretty fairly common, we have to be wary of some of the red flag signs. So often you'll hear patients complain of non-traumatic back pain that radiates down their legs. The radicular pain, it's important to remember the radicular pain aspect of it is not super concerning in terms of a severity or acuity standpoint, but when you have radicular pain with what we call red flag signs, that's important to identify. So what are the red flag signs? We talk about red flag signs as being a sign of possible concern for something called cauda equina syndrome. So the red flag signs would be urinary incontinence or retention. So are they peeing or pooping themselves, or are they unable to pee or poop? Sometimes you'll hear that, I peed myself or I pooped myself, but then differentiating why did they pee or poop themselves? Was it because they couldn't feel the sensation and it just came out? Or was it because the pain was so bad that they couldn't get to the bathroom in time? Something called saddle anesthesia is good to ask about. You're not going to ask the patient whether or not they have saddle anesthesia. What I like to ask is, are you having any numbness or tingling in the area where you pee or poop? Patients can easily understand that. And are they having any weakness in your lower extremities? Those are usually the red flag signs for cauda equina. Some other patient populations that we worry about back pain more are the elderly, patients that have cancer, patients who are immunosuppressed in any way, that are at risk for infections. So if you have history of IV drug use, or if you're immunosuppressed because you're on chemotherapy or any other immunosuppressive agents, those are really important things to elicit. So keep up the good work in triage, and hope that helps your triaging skills for back pain.
Okay. You're good.
Hi everyone, today my name is...
Okay.
Hi, my name is Victor Chan. I am an emergency physician at a trauma... Are we level 1 trauma?
We just want to say thank you to Dr. Chan for taking some time out to help us assess our back pain patients in triage. So stay tuned for more triage tips. Thanks.
Thanks, Chan.